Welcome to Practical AI in Healthcare, the podcast that cuts through the noise to spotlight real-world solutions delivering real-world value. From patient care to clinical research, from life sciences to patient engagement, we focus on what truly matters in healthcare today. No hype, no theory, just practical insights where AI is making a true impact. Dr. Stephen Lapkoff and Dr. Leanne Rosenblit are your hosts as we explore what's real and moving the needle in this exciting new domain. Welcome aboard and let's get to it. As many of our listeners know, Leon and I work very closely with the DCI Network, a division of clinical informatics at Beth Israel Deaconess Medical Center in Boston. This June, the network is hosting Patient Powered Digital Health 2026. The conference will bring together patients, innovators, industry leaders, healthcare providers, and policymakers to shape the next generation of real-world, patient-centered solutions. The meeting will run from June 22nd to the 24th in Boston at Harvard Medical School. We've arranged for our listeners to get a discount on registration to the meeting. If you register now before June 15th and use promo code PracticalAIJune, no spaces, you'll receive 30% off your registration fee. You can learn more at dcinetwork.org/patients2026. In addition, we're always looking for sponsors. If you or your company are interested in becoming a sponsor, please reach out to admin@dcinetwork.org. See you in Boston. Hello, and welcome to this week's edition of Practical AI in Healthcare. My name is Dr. Stephen Lapkoff, and I'm here every week with my colleague, Dr. Leanne Rosenblit. How's it going, Leon?
Great, Steve. I'm really excited to have our guest today, especially on National Nurses Day.
Yeah, I think this we lucked into this recording date, and we have actually today is the first time we've actually had a nurse on the podcast. And to that, I want to actually apologize to the audience and apologize to Sarah, who we're about to introduce. We've been remiss in having the nursing informatics perspective on the podcast, but we're going to remedy that today. Today, our guest is Sarah Rossetti. She is a PhD nursing professional out of Columbia University, and she has done some absolutely amazing things that we're going to talk about today that revolve around nursing care and patient risk and involving AI and modeling, which has been some of the most groundbreaking work that's ever hit the scene in my entire career, to be honest. And we'll unpack that as we go through it. But before we go on, Sarah, welcome to the podcast.
Oh, thank you so much. Thrilled to be here.
So, Sarah, we wanted to speak to you and have you, first of all, the first question we usually ask our guests is, how did you get your superhero cape? How did you get from, through your career and to where you are today? And how did it all result in you landing in this chair today?
Great question. So I think I would start by talking about where I started clinically. I was very fortunate so I went to University of Pennsylvania, first my nursing school as an undergrad. And straight from there, I was able to go to the new graduate critical care program that at the time Mass General offered. And so had 6 months of some additional training there and starting right off in the CCU at Mass General. The reason I talk about that, it was a very interesting time there. We were on essentially hybrid charts. We were using paper-based flow sheets. We were using CPOE, electronic orders. And so really started as I was a novice nurse, observe the systems around me, how they were working, how they worked well, what, could still be done. There was obviously all the work done there at the Lab of Computer Science for many years. From there, I worked as a travel nurse. And so I worked at a community hospital in California and saw different systems, saw how those impacted work. And after that, worked in New York and started my PhD program in nursing informatics. And so those clinical experiences and some very specific patient cases got me asking questions about how these systems influence how we document what we do and observing how nurses practice and record their care. And so during my PhD training in nursing informatics, I really, was thinking through many questions that still today researching and answering. And so I completed then a postdoc in biomedical informatics at Columbia University at the Department of Biomedical Informatics. I worked back up in Boston for about 7 years at what was then Partners Healthcare System, and with an appointment at Brigham and Women's Hospital and Harvard Medical School as really doing a blend of operational informatics work and research as well. And at that time, and I know we'll talk about the concern study. That's when I put in with Ken Ricato, my MPI, for grant funding for that. And then I've been back at Columbia, jointly appointed in the Department of Biomedical Informatics and in the School of Nursing. And I've been back for about 8 years now.
Wow, we have a couple of the intersection points in common, although I don't know that they temporally interacted. I also trained at the Brigham for my
Yep.
fellowship time back in the day, but that was
Yeah.
probably a much longer time ago than you were there. And did you interact with Octo Barnett when you were at?
No,
No, was he already
no,
gone by
I
the
did
time you went
not.
through?
I think so. I
Ah,
think
okay.
so. Yeah. Yeah.
He's one of the grandfathers of the field, and I
Yeah.
got to interact with him when I was working up there. But again, it was many, many years ago. So tell me a little bit about, you know, nursing hasn't, we dropped the ball in getting nurses involved here. I know that AMIA, the American Medical Informatics Association, has not always been as sensitive to bringing nurses into the picture, but nursing is at the forefront of patient care. Nursing is the very, the spear tip of patient care. And nurses see and record things that are incredibly important, incredibly valuable, and yet it doesn't always bubble to the top. Maybe you could unpack a little bit about that with regards to what you saw at the CCU at Mass General. What
Sure.
made you lead to the Concern Project?
Yeah, sure. So there's this concept of nursing surveillance. So when we're talking about nursing in the hospital setting, nurses do many things. They're coordinating care, they're administering medications, they're assessing patients. But within the nursing process, there is this um, this very clear activity of nursing surveillance. And the nurse is assessing the patient, observing for changes in the patient's condition, and responding to those changes, whether that's an additional intervention, an additional assessment, oftentimes more frequently assessing a patient that they suspect might have something brewing. We use that term clinically, right? Oh, there might be an infection brewing. The
Mm.
patient looks a little bit different. And so they're paying more attention. And this process is very dynamic. It is not captured in our documentation well. It's not captured in our electronic health records. If you think of the EHR, there are many structured data points, especially over the past 20 years. Nurses' documentations become highly structured. There's actually been a lot of movement away from narrative nursing notes. And so we have these discrete fields that don't link. Yet the nursing process and nursing surveillance is linking these fields. So I'll use a really specific example. When a patient in the hospital has a normal oxygen saturation in their flow sheets, maybe they're 98%, almost all day. They're bouncing right around those high numbers. But a nurse puts a comment into the flow sheet saying, well, now they're at 6 liters, inferring in the morning, maybe they were receiving a low level of supplemental oxygen at 2 liters. Now they're receiving 6 liters of supplemental oxygen, the max through your nasal cannula. That is really informative, but there's no great way that our EHRs really surface that information. The nurse puts that comment in to communicate this point of 98% is not telling you anything. This patient is not doing well. They are decompensating, even though their value looks normal. And so, amidst all this, the nurse is speaking with the care team, the nurse is escalating discussions to see what else should we be doing? Is somebody else going to come check on this patient? What is the plan? And that's a process that's, for the most part, invisible in the data that we analyze for patient outcomes.
And, one of the things, as I've mentioned, I trained as a cardiologist, so I was in the same zones as you are, not at the
Yep.
same time. But whenever I would make rounds, the very first question is, going to the nurse, what's going on? Because the nurses would have the most accurate perspective on exactly what was going on. Because as a clinician, as a physician rather, I don't spend every day at the patient's bedside. I don't spend hours and hours at the bedside, but the nurses do.
Yeah.
And they actually, in the CCU setting, generally they had two patients, maybe one, maybe in a step down unit it's three or four, but it's not a big ratio. It's not like 10 to 1 on a med surg floor. So the nurses get the most accurate, and then they have this gestalt. They have this gut feeling about what's going on. And I've been oftentimes wondering, especially since I've read some of your papers and read through your work, how do we capture that gestalt? How do we do that? And I guess is that where you began to get the beginnings of your thoughts around building the concern? And maybe you can even unpack what the concern acronym stands
Yeah.
for and go through
Yeah.
all that.
Yeah, without a doubt. And it really is expert and assessment by the nurse. We say it's that insight or that gestalt, but it really is based in evidence and experience. So when I was a new nurse and I was trying to kind of understand, how these systems worked, how the more experienced nurses were interpreting patients' conditions and states, what I observed is that, and this was when flow sheet documentation was on paper, that for the patients that these more senior experienced nurses clearly were not worried about, and this was in the ICU, there was a lot of white space on the paper, not densely recorded. But it looked very different for patients that clearly in receiving handoff, this nurse, had some concerns and was worried, and in perhaps in that handoff guiding me on things to keep an eye out for. That was a densely packed flow sheet. And so that was the first observation I had, which led to asking this research question of, can we understand a nurse's level of concern from the density of their documentation, which is what the concern study is at its core. We've built a machine learning based model that uses the metadata patterns within nursing documentation to predict patients at risk of deterioration. So outcomes such as needing a transfer to the ICU, because the model is both for acute care patients as well as ICU patients, risk for mortality in the hospital, risk for a rapid response, risk for sepsis, for example. And as our modeling has advanced, it's not only the frequency in which nurses document vital signs or comment associated with those vital signs or increased notes, it's also when they do it at uncommon times. So in the acute care setting, if a nurse is going into a patient's room at 3 a.m. and recording vital signs, you might ask, well, why? Because it's typically important to let patients rest who are in a condition where they should be, which really should be most acute care floor patients. And so these signals are actually quite strong, and we've been able to model them out and predict deterioration just about 2 days earlier than other early warning systems. And colleagues from the University of Utah actually took one of our less advanced models and replicated the ability for good predictive performance in the EICU collaborative dataset, which is a dataset of over 200 hospitals throughout the country. So we've shown the generalizability and reproducibility of this modeling approach. This is a nursing practice that is very consistent, at least across our country, and we're starting to explore areas internationally where we might, hopefully learn if it holds there as well.
So Sarah, really fantastic findings, and and I want to dig into the method a little bit. Before we get into the math and the model architecture, I want to slow down and teach us and our audience a little bit vocabulary. I think the audience of this podcast leans heavily physician, exec, and informaticist, and most of them have a rough mental model of what a doc does. on rounds, but fewer of us have, including myself, have a clear picture of what a nurse on a medical surgical floor or in the ICU is doing throughout a 12-hour shift. In particular, what kind of trace are they leaving under normal circumstances in the EHR? And you've mentioned some of it, flow
Yeah.
sheets, but can you walk us through that and sort of explain the touch points of what does the normal record keeping look like?
Yeah, sure.
Karen?
Yes. Yeah. So let's talk about, a day shift starts at 7 a.m. This is typically a 12-hour shift, 7 a.m. to 7 p.m. The nurse will come in, and in the ICU typically has about 2 patients, excuse me, on an acute care floor, in the range of 4 to 6
Mhm.
ish. And so we'll receive handoff from the night shift nurse, and then once that process is done, probably within the hour, go into their patient's room. Handoff sometimes is at the bedside, with
Mhm.
the night shift nurse. But then once that handoff process is over, then go into the patient's room and do a head to toe assessment of the patient.
Mhm.
And this assessment, certainly is specific to the conditions and the reasons the patient is hospitalized. If you're on a neuro floor, there's a much more detailed neuro assessment done for a patient, for example, and the same likewise for a cardiac floor in a cardiac patient. But that head to toe assessment's done. If the patient's sitting up in bed, talking with the patient, getting a sense of, okay, how do they respond to me? How are they, what's their cognition like? How are they mentating? Putting those pieces together, does it align with the handoff report that I got? Or if I previously cared for this patient, does it align with how they looked yesterday? Typically, after that head to toe assessment, a lot of medications are often due in the morning. Um, Now, on an acute care floor, you're checking your patient's vital signs maybe every 4 hours. It depends on the standard of care of that unit. In the ICU every hour. So the nurse is going into the patient's room in kind of these regular times.
Mhm.
And every time they go in the room, they're assessing the patient. But I'll use another example. They'll record those assessments in the morning, the head to toe assessment when they need to, vital signs when they're due, within an approximate time range, but they're always assessing the patient. When I walk into a room or seeing the two of you on the screen right now, I can pretty much interpret that your respiratory rate is within normal rate. you know, yeah,
Mezza mezza.
within
Yeah. Yeah.
reason, right?
Yeah.
Within reason. So I use this example because this is a manual process, right? You're supposed to actually, count the respirations within, however many, seconds and compute it to within a minute, right? Um, the nurse is doing that when they walk in the room. They don't always record it in the EHR though,
Right.
because, okay, I looked at the patient, I could tell that they were within normal. But when we start to see those extra recordings in the
Mhm.
EHR, that's telling you, okay, there's something here that the nurse is giving extra attention to that assessment that doesn't always warrant the actual documentation of it. And so when
Right.
we start to see those escalations, that's a strong signal that the nurse is worried about something, worried early on. And actually, sometimes it is hard to pinpoint exactly what that worry might be,
Mhm.
but it's the reassessment that the nurse does because they're trying to figure out, why is this patient not looking right to me? There's something about how they're looking or how they're talking, about something about what they said, or they not mentating right? And I'm going to keep reassessing them to see if my concern should be escalated to the care team. And
Yeah.
it's this early process, which nurses do day in and day out in hospitals, that we're able to tap into. And that's why our prediction can be that much earlier than any vital sign change, which is a vital sign
Mhm.
change, moving from your normal state to your abnormal, is a late indicator. And the same with lab values. The
Right.
the other point I'll make, just briefly here, is it's not always that your vital signs abnormal. It might be oftentimes in our model. Actually, another strong signal is when a nurse holds a medication.
Mhm.
And so if you're going to a cardiac example, a lot of patients might be on a blood pressure lowering medication. Um, because typically their blood pressure is high. But the nurse may note, oh, their blood pressure is lower than their normal baseline. It's within normal, right? But for
Hmm.
that patient, it's not normal. I'm not comfortable giving this blood pressure lowering medication because why are they so much lower than their baseline right now? What's going on? So when you see a
Yeah.
nurse make a decision to hold a medication, such as one that can influence, a clinical condition such as that, or bottom them out, as we might say, that's an indicator too. Also, giving PRN medications. This you can see how that might be the case. You give Tylenol for suspected infection or something. You can see that. I think that's an area we still really want to dig into. What are these medications that have the strong signal, and why? What are
So
those
Sarah,
decisions that are being made?
I think that's super helpful, and the examples I think are really evocative. I mean, you're describing the nurse as a super sensitive sensor that's deeply aware of everything that's happening with the patient and is an early detection
Yeah,
system of things that won't show up in other ways for a period of time. So I think that thank you for
yeah,
helping us sort of set the ground and really help us understand what's happening on the floor. So let's go to the move that you made, which is genuinely interesting and unusual, right? So a lot of people studying patients that are getting acute care would, for early warning signals, would try to model the patient or their
yes,
physiology and say, what's the patient's system, right? Let's look at the telemetry, let's look at the biology. You instead modeled the nurse as the sensor system, and in fact, specifically looking at the documentation trace that they're leaving as the proxy for what the nurse is thinking, right? So that's
absolutely.
beautiful,
Yep,
beautiful, beautiful example of making use of existing observational data, right? So you got to take digital exhaust and mine it into something that's really interesting. So um, help us how you got to the modeling and the architecture. So I think you explained the
yeah,
intuition, right?
yeah,
The nurse is seeing stuff that others don't. But how did you think about the signal, extracting it from all that noise and creating
yeah.
models that are able to turn it into something usable?
Yeah, yeah, great question. So, we started with vital signs and
Hmm.
looking at the frequency and the patterns in which those are documented. And so we have some early publications where we showed there's an association between actually vital signs overall, but when you even look across the different ones, the frequency of them and mortality and actually and cardiac arrest. And so we knew there's a signal there, and so we modeled each of those out. We also, thought early on would be looking at some narrative information too. And there is a signal in um, mentions, for example, of MD aware.
Hmm.
And it makes sense, right? So the nurse is documenting that they escalated a concern. The MD, the doctor, is aware they communicated that concern. So we looked across the board of nursing documentation, to see where the signals might be. We knew early on, these signals that looked at frequency, were pretty strong, and like I said, those are the strong predictors in our model. I want to acknowledge Ken Cato, my MPI, on this. He had incredible insight to looking at some broader signals too, really around seasonality is in our model. Um,
Hmm.
these different types of temporal signals. So we have an ensemble-based modeling approach. There are about 1,200 models within our system, concern system. What it does is it looks at, for instance, the characteristics of that patient at that time. What hospital day is it for the patient? Um, what day of the week is it? Is it night shift? What season is it? And what it says is based on those characteristics, then picks the right model that then knows what the common documentation pattern is versus the uncommon. And if it's uncommon, then that tends to pop up as the signal.
Yeah, Sarah. So Sarah, there's what you described. I think reminds us of the line from the rapid response literature from 20
Yep.
years ago. And I think you
Yep.
mentioned it, right? Where when the nurse is worried about the patient is
Yep.
considered a perfectly valid trigger to escalate, but nobody could measure it. And I think you figured out how to measure it
Yeah.
by looking at existing documentation trace. My slightly nerdy question is why the ensemble architecture, right? Why the choice of 1,200 separate ML models that
Mhm.
look at sort of specific times a day? Like, and understand there's variability,
Yep.
right?
Yep.
As opposed to some other architecture. Help us understand
Yeah.
that architectural choice.
To put this in context, so we were
Mhm.
building the model between 2017 and 20 20-ish.
Mhm.
And our thinking really was we want to be able to understand what are the features driving this model, and so that we can expose those as well to
Ah.
the end
Mhm.
users, so that to the end users, so that they can have faith and trust in this model. um, uh, an important point to make is whenever we did a lot of training with our end users, so we tested this in multi-site randomized control trial, training with the end users before we deployed it. Training with nurses was simple. They got it. This is their documentation pattern and process. With physicians, they were certainly on board with it, but we had to explain how this works and why it works, because it
Mhm.
wasn't intuitive to how they may interpret documentation, and certainly not consistent with other types of predictive models, and how it would be arriving at that prediction. So we do provide the kind of ranked features that were driving the prediction for that specific patient on this kind of drilled down screen that is available. We understand clinicians are busy, so with a lot of user-centered design, we made it so they can quickly get 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 the risk level, but if they want, they can look at the drill down.
So, Sarah, I wanted to sort of like dig into this a little bit further, um, because what I'm trying to understand is, as is this a matter of the frequency of documentation, or is it the values of the documentation? Because what I'm hearing you say is a little bit of both. That the nurses, by the virtue of the fact that they're putting something on the virtual flow sheet, which would, in my day, would have been a big piece of paper or a giant
Hmm.
piece of paper,
Yeah.
and the frequency of those notes appearing is one kind of signal. The actual value that they're generating is another kind of signal. And you found a way to sort of, maybe you can unpack that. Are they
Yeah.
married together, or are you looking
Um,
at one as a lead to the other, or how is that part of the model?
and what do you mean by value
So,
there?
like you were saying, the 6 liters of
Oh,
nasal
right, right,
cannula,
right.
that's a value. The
Thank you.
respiratory rate is a value, which is an objective value. It's something you
Yeah.
could measure. But what's something that you're not measuring is like that spidey
Yeah.
sense going off in the nurse's head, and the proxy for that is the frequency of the documentation.
Yeah. The signal is in the frequency of the documentation. With that is the common versus uncommon time, right? The importance of the
Yeah.
temporality of that
Right.
frequency. That's key. The value is not what is driving the prediction. Now we've put in values because we want to make sure when you get closer to that patient event, we want to be aligned with other early warning systems. You don't want it to be saying something different than the news, of course not. So you can add in the actual vital sign values, but they don't give you an early prediction. So our early prediction is driven by frequency and the temporality aspects of this information.
And that's the stroke of brilliance. It's like, Leon mentioned it earlier. Most people, myself included, would look at the patients and try and find commonalities. Like all the sepsis models that are looking for sepsis, risk of sepsis, they tend to look at the patient. They tend to look at the lab values for the patient. They tend to look at but what they don't tend to do is what you've described, which is that patient's looking pretty punky, and there's like 5 notes in an hour, and that in and of itself is the signal.
Yes,
And
it
that's
is.
that's that's
It is.
that's a stroke of brilliance. So you did this. This study is huge. You did this over an enormous swath of institutions. Can you
Yeah.
unpack that a little bit? Because aside from the AI stuff, which we try to really dig into in the podcast, which we're doing a bit, I'm
Yeah.
also enamored by the fact that you did this over an enormous number of institutions. How'd you pull that off?
Yeah, I think there's just one phrase, team science. I mean, it really, really, we had an incredible team. Um, so we did the trial during 2020 and 2021. Some interesting years.
What was going on then?
And
I don't
yeah,
remember. Was
exactly.
any?
I know. I don't remember now.
It was boring. It was so boring
Yeah,
we forgot. It was
I
boring
wish
you.
I could forget, honestly.
exactly.
Yeah.
Well, here's the other interesting tidbit about that. So at Columbia, we went live with Epic in February of 2020. So
Oh
that was
man.
it was an exciting time. So we actually so knowing that date, those go live dates well in advance. So we delayed the trial at Columbia, knowing that, and it ended up being a good decision, all in all. So we actually so our sites were Columbia, the two hospitals at Columbia University Medical Center, and then two um, up in Boston, Brigham and Women's Hospital and Newton Wellesley Hospital. So each had an academic one with the partnered community hospital. And so we went live up in Boston a year before. In late 2020, I want to acknowledge Patty Dykes. She was our site PI up there, and she made that happen. If you ever want to know something about implementation science, talk to her. She had laid that groundwork. Everything was ready. COVID came, and it was clear we were ready to go, and this might help. She's a genius in that regard, and was able to make that happen, because you can imagine it could easily have been not feasible. And then the year later, we went live at the Columbia site.
So it was 74 units, not 74 independent sites. 74 units.
74
But it's
units,
still a
yes,
lot. I mean, that's
across the
still a
four
ton of.
hospitals, just
That's
over 60,000 patients.
Yeah, that's still a ton
Yeah.
Yeah.
of places to take it. So the acronym, I think, stands for Communicating Narrative Concerns Entered by Registered Nurses. That's the acronym for
That's the
consent.
acronym. Yeah.
And, walk us through, I guess kind of we've covered it to some degree. The things that you found were basically what we've been talking about, the frequency of the signals, the frequency of the concerns, and that's what really raised the issue. And then that resulted in some pretty amazing findings, like 35%, 35.6% reduction in instantaneous mortality risk and 11+% in shorter length of stay. Those are spectacular interventions. I mean, astounding. Can you unpack that a bit?
Yeah, absolutely. We were surprised by the increase in ICU transfers. So it was this great decrease in mortality risk, a decrease in risk of sepsis of 7.5%. Overall, half a day, just over half a day shorter length of stay, increased transfers to the ICU. So this right off the bat, as we're as we completed the trial, that was our first sub analysis. What was going on with these ICU transfers? So uh, what we realized is we can measure deterioration, because we now have, so concern runs hourly, so we have hourly scores of that patient's status. Prior to that, you can't really measure deterioration. We measure outcomes. We measure that they had mortality. We
Right,
measure that
right.
they had sepsis. But what happened in this whole process, the day before, the day leading up to, the 2 days leading up to. So we now had these hourly scores. And so we were able to look at, for our intervention units, what those hourly scores were. When it first changed, our score is red, yellow, green. So when it first changed from green to yellow, how long until the patient was transferred to the ICU for patients, that needed to be transferred? What happened to them? And so we were able to show that the patients transferred early, they had much better outcomes, highly statistically significant. Those late transfers did not do as well. Those had those were the patients that that did die. This, if you talk to a clinician, you guys would know, of course, an early ICU transfer is going to go much better than a late ICU transfer. But the literature doesn't have great evidence about this, because we can't measure early versus late ICU transfer. And so we were able to unpack that those increased ICU transfers in our trial on our concurrent intervention units really were a mechanism that was leading to better outcomes.
And that I got to guess that initially there must have been some people out there who said, "Oh my God, you're sending patients to the ICU center, more ICU time." It's exactly the opposite. By virtue of the fact
Yes.
that you've intervened, those outcomes long term, the patients are going to do better, and it makes perfect
Yeah.
clinical sense.
Yeah.
But if you're a bean counter looking at this, it might make a bean counter get a little panicked and say, "Oh my God, we're raising the number of patients going to the unit," and ironically, it's exactly the opposite. Because you're doing that, you're utilizing the ICU in a far better way and getting the real value, which is early intervention, early treatment, and that leads to better outcomes. And that's the whole idea of the ICU in and of
Yeah.
itself.
Absolutely. We've actually recently partnered with colleagues from Columbia's Business School on doing a cost benefit analysis, and it is definitely a net benefit for hospitals.
Yeah, I'll bet that's an interesting finding.
So, Sarah, I want to probe on a methodological issue that you raised on a prep call yourself. I think it's worth discussing, and it would be important to the audience to understand. So, you said when you're doing deterioration work, you don't have a measure of
Yeah,
deterioration, right? That's a deep epistemic problem, right? It's a
it
kind of a
is.
proxy measure, index measure problem that we struggle with in clinical research all the time. You're predicting an event that doesn't have a clean ground truth and
Yeah.
may never have a clean ground truth. So how do you know your alarm bell fired correctly versus that a sicker patient just got sicker for unrelated reasons? So walk us through how the team handled the absence of a gold standard.
Yeah, sure. Um, Yeah, so a few things there. I mean, you have to be really clear about the outcomes that you're
Mhm.
trying to predict. And we had what we call kind of a composite set of outcomes. And there are the outcomes that you have for creating your predictive model and testing the performance of it. And then to be really clear, then you need clarity on what, for us, we had a clinical trial, what those outcomes are as well. Um, but eh, i- so we were focused on ICU transfer, rapid response, cardiac arrest, and sepsis and mortality. Um, and we had to be really clear about the fact um, that well, I'll answer in two ways. So you build your model and you look at those outcomes. We did chart reviews to make sure our outcomes were well defined and validated for sure. Um, but as you actually move towards intervening, you have to be
Mhm.
clear about how you're. We did a multi-site randomized control trial, so we have that difference. But if you actually turn a score on and start to intervene, you then you don't know. If that outcome was avoided or and
Right.
your score was actually having that impact or not. So there's a lot of thought that needs to be put into how you actually, what context are you evaluating these outcomes in, and how. So us now being able to actually look at these hourly deterioration scores, we think that offers a lot.
Mhm.
We're actually working on being able to have those scores that have run silently in the background, because then you can infer some other information from that. For any sites that aren't live, what was the score for that patient? And then what, that you didn't actually have that live intervention going on that could have moved the needle this way or that way.
Super interesting. I think what's valuable for our audience to recognize here is that with clever methodological thinking, right, with stepping back and thinking hard about measurement, you can often develop ML training methods even when it's not obvious that there's a ground truth and a gold standard, right? That's easy to anchor on. But it just requires really hard thinking and some sophistication. So let me kind of ask you about the kinds of concerns people raise about AI ML methods of the kind that you guys develop, right? So critics of clinical AI typically complain about three things, or they worry about three things, sometimes justly. One is alarm fatigue, right? It's
Mhm.
just like, oh man, another freaking alarm, come on. Another is generalizability beyond the training site, which you partially address by
Yeah.
having multiple sites and follow-up studies. And then equity, then the sense of whether the model works the same across populations and care settings. You've addressed one of them at least, and perhaps
Yeah.
alluded to the other. But can you talk more specifically about how your team thinks about those three concerns, and what
Sure.
have you done so far?
Yeah. We thought about those for years.
Yeah,
Absolutely. So important. I also, a little side note, I research documentation burden as well
yeah.
for a large part of my work. So alarm fatigue, huge problem. Our system does not have a pop-up or fire an alert or interrupt in any way. We
Hmm.
worked with end users on what's the user-centered design that fits. Where would you want to see this in your workflow? And recognize too that that may not always be the same answer. And so what we built is that we actually write the score back to a flow sheet row, so it's available in the system for anywhere we want to produce it. So that's kind of the architecture there. That if we find a different patient population or workflow is important, then we can surface it in the EHR that way. So, for example, we put it on the patient list in the EHR, because by and large,
Yeah.
that's where, this is being displayed to the nurse, the physician, PA, and P in the inpatient unit. That's by and large where they go. Every time they log in, they could see it. There's a small asterisk next to this icon of regular green circle. If there's an asterisk, it changed in the past hour. That's all
Hmm.
the information they need to act. Like I said before, they can double click and drill down. Great, that's there. It can enhance trust, but for the most part, busy clinicians, they don't have time for that, and they don't need to if they can just see if it changed in the past hour. But we could build this in a different place in the EHR for a rapid response team, for example. And so we had that vision in mind. So key, absolutely, working with end users. One other point, you talked about alarm fatigue, but around documentation burden, we do not ask the nurse to input any additional data. So
Yeah.
this is not a score where their morning assessment needs to be done in order to get some discrete field in. No way. We were not, going to go about it that way. In
Yeah, it's
terms
part of
of
the genius of your approach, right? It's
yeah,
like, look, you're
yeah.
writing stuff down. That's the signal. So,
Yeah, exactly. In terms of equity, hugely important question. So we did look at bias within our data outputs. We know that there's bias within EHRs. We know that there are bias patterns. So we looked at our outputs to see if there were differences in the distribution of outputs by race. And we did see that there were differences. And so we
mhm.
did account for that in our model that we deployed. We also looked at differences in comment documentation. I talked about nurses' comments a little bit. So, in the frequency of comment documentation by patients who are English speakers versus non English speakers in terms of primary language. And we found differences there too. So, these differences are in there in the patterns in
Yeah.
the data. We leverage patterns. So, we need to look for these. It's just scratching the surface. So, I want to be clear about that. This is a really important area within AI to figure out what are all the ways that we need to look at bias and mitigate bias in our outputs.
So let me tackle a more positive side, right? So I mean, I'm imagining being a CIO of a health system, a CMO, and saying, "Man, I want this." The concern algorithm is IP, right? So somebody who owns the copyright. As far as I know, it's not in the public release.
Mhm.
The de-identified outcomes are all going up on PhysioNet. But imagine that I'm a health system that's listening to this episode and going, "Oh my God, we got to implement this tomorrow."
Yeah,
What's the path? Do they replicate from the methods? I mean, your paper is, Nature
yeah,
Medicine.
yeah,
Congratulations, right? Should they wait for commercial product? Should they license it from you? What does the next year look like for diffusion of this
yeah.
very, very important finding?
Yeah, so we are implementing at other sites with funding from American Nurses Foundation. So that's
Mhm.
Vanderbilt University Medical Center and Washington University, St. Louis. And then we're building out, I'll just mention a pediatric model with Children's Hospital of Colorado. So there is work to expand right now. In terms of other sites that want to expand, we built with funding from American Nurses Foundation an concern implementation toolkit that's online. And that has all the information you need, from how to pitch this to your hospital executive, to some of the technical documentation, to how to train your end users. What it doesn't have is the actual software code. And so
Uh-huh.
for that, we would enter into an academic research license and would be more, would be really happy to engage in conversations to see if this is a fit and if we should proceed with that. And uh, I know this is how we both feel, so I feel comfortable speaking for Ken Cato, the co-lead with me on this. We want to see this in every hospital in the country, because we know this is how nurses practice, and this is just valuable for patient outcomes.
Yeah, and it's, the fact that you've been able to demonstrate this in a reproducible way in
Yeah.
multiple institutions across multiple different populations, and it holds up really well. That's about as good as it gets. I can't imagine anything beyond that that would make it even more credible. Um, I do want to ask you a little bit of a provocative question. EHR documentation, you said you've studied this. It's become the bane of the existence of a lot of clinicians. Certainly, my friends who are still practicing find EHR documentation to be terrible. Does that, what degree is that going to impact what you're doing? But you've already said it's the frequency of the documentation, not the actual notes, not the actual information. So I'm just trying to get a sense of, does the documentation burden have an impact on your algorithm, or is it just completely, does it not matter?
Steve,
Yeah.
if I can jump in, I think the real crux for us for our podcast is the enormous transformation
Yeah,
with ambient
without a
AI,
doubt.
right?
Yes. Well,
Without a doubt.
And
Without a doubt.
scribes, right? Like, is that going to make the job of nurses creating the signal
Yeah.
easier, or is it going to completely mess it up, right? What?
Yeah.
and the frequent, yeah, exactly. Thanks, Leah.
Yeah. Yeah. I love this question. And of course, the researcher in me, I couldn't be more excited.
Yeah.
I'll answer specific to one thing about documentation burden, because I think it informs what we might see in the future. Is that in some other work that I've done, we've seen during the COVID pandemic, requirements for documentation were relaxed. Nurses and others just had to document medications. So we performed a natural experiment of what did nurses document at that time then when they could choose. And they captured what we then with mixed methods confirmed to be essential documentation. They maintained high levels of documentation that was informing clinical care, coordination, communication. Those are what we're tapping into in the concern model too, right? These
Mhm.
signals, they maintain that even when we say you don't have to document these other things that are kind of for secondary purposes, or all of the reporting requirements that we place on nurses. So I say that because as we transition to these new modes of data input, I'm really excited to be able to, in an even bigger way, model nurses' behavior. Because at the end of the day, that's what we're doing. We have these proxy measures. So maybe we're one step away from that actual behavior. It's the behavior of inputting into the EHR. So now we could be even closer. So with ambient, hearing what they're doing, how frequently are they in the room, we're closer to that actual detection of this interaction with the bedside. And then computer vision technology, I mean, to actually see what's encountering. So I'm really excited to model nurses' behavior in an even more granular way than we could imagine right now.
Yeah, there's such cool opportunities emerging. And the method reminds me of a very old social science finding, and I'm completely blanking on the reference, but it was a juvenile delinquency prediction model that found the best predictor of juvenile delinquency was the size of the file on the kid.
Mm,
So just measured in
yeah,
inches, and you're like, yeah, that's a big file, man.
yeah,
That's kid's trouble, right? Brilliant, right? Absolutely, brilliant use of kind of created, derived artifacts and
yeah.
and signals in the system.
And
So I think this is
hiding in plain
Hiding
in
in
sight
plain
plain
too.
sight, in
sight.
plain
Hiding in
sight,
plain
yeah,
Yeah,
yeah.
sight.
And quantitative measures from kind of created out of the exhaust. So very clever stuff. But let's try to bring this to a landing. I think we imagine that a health system CIO is listening to this and then has 60 seconds in the elevator with their CMO and the CNIO tomorrow. And what's the one thing about concern or about modeling clinicians instead of patients that you want them to walk away knowing?
Yeah, that these nursing behaviors have an outsized influence on patient
Mm,
outcomes.
mhm.
I think clinically, we've always known that. You pointed out the rapid response literature for years that if a nurse is concerned, then act, but we can now actually measure it. And so
Yeah.
this is a use case and a really valuable use case for it. Absolutely. And I think that we can learn even more and apply it, this method and this approach and what we can now measure about nursing care and I think healthcare processes in general. Um, we I think we can think about even more use cases to understand what our expert clinicians are doing in a
Mm.
way that um, that we haven't been able to measure that expert decision making before.
Yeah, I love that. So the system as a whole is generating signals, not just what you're measuring about the patient, right?
Yeah,
That's such a
absolutely.
profound insight. So to push that just a little bit further, what's the first concrete step that a health system could take if they wanted to start working in this space? Not necessarily implement concern, right? Maybe they're not ready for that, but what kind of capacities, capabilities recognize that nursing data is signal and not noise?
Oh, great. Um, I would say I would say let's remove some of the burden that we impose on
Mm,
nurses
Amen.
mhm.
because we
Yeah,
take up too much of their time and time is limited. And so it's the nursing surveillance that is influencing these patient outcomes. And if we fill it with tasks, then nurses
yeah,
don't have time to engage in that. And it's really important to be able to engage in that, think through what your patient needs, go in and reassess the patient. And this is um, limited time that when AI saves time, we add on a task, and
we
we
add on a
can't
task.
keep doing that.
Yeah. And I think the profound insight is a nurse who is filling out a form is not eyeballing the patient, right? And saying
Exactly.
like, boy, that's funny. That, and that turns out to
Yeah.
be a critical function. So
Yeah.
to wrap it up, where can people learn more about your work, the trial, the 25 by 5 task force that you're leading for EMEA, which we didn't even get to talk about, and
Yeah.
how to reach out to you and the team? Where do we
Yeah.
look at?
Great. So our toolkit is at concerntoolkit.org. And then we also have our study website on Columbia's Department of Biomedical Informatics website, and it's under Concern Study there. And happy to
Brilliant. And
provide
we'll
the exact links to you.
Yeah, we'll post
Yeah.
it in the show notes for people who I'm sure will want to look it up. Well, with that, Sarah, I wish we had more time to dig into the many other exciting things you're doing, but you've been such a wonderful guest and reminded us why we absolutely have to have nurses as part of this conversation. So thank you so much, Steve. Thank you for, as usual, for co-hosting. And I want to thank our audience and invite everyone to join us for another exciting episode next week of Practical AI in Healthcare.
Thank you so much for having me. This was wonderful.
Thank you for joining us this week on Practical AI in Healthcare. If you're ready to go beyond buzzwords and hype and explore how AI is truly transforming healthcare, stay tuned for more conversations that get us to what works. Until next time, stay practical.